We have a really exciting issue this month, beginning with an article from Diabetes Care where we are going to be talking to the first author on, ready, a large language model, GPT-4, compared to endocrinologist responses on initial choice of anti-diabetic medications when that choice is filled with uncertainty and disclarity. This is going to be an absolutely interesting discussion on a cutting edge area, followed by an article from eClinical Medicine Lancet titled Long Term Health Outcomes in People with Diabetes 12 Months After Hospitalization with COVID 19. Then, an article from Diabetes Care on the risk of nephrolithiasis associated with SGLT2 inhibitors versus DPP4 inhibitors among patients with type 2 diabetes. Then we're going to discuss an article that was in JAMA Internal Medicine, and we're going to talk to the author about early screening for latent autoimmune diabetes in adults. That's LADA. Finally, we're going to discuss an article about Project Echo Diabetes and a trial that showed that educational program improves outcomes for medically underserved individuals, and we're going to talk to the author of that trial as well. Our first article this month is a really exciting article, and it's from Diabetes Care and is titled The Large Language Model, GPT-4, Compared to Endocrinologist Responses on Initial Choice of Anti-Diabetic Medication Under Conditions of Clinical Uncertainty. And I got to tell you, what I love about this whole idea is that this isn't how GPT did on a test, but it's how it does in real life, in the mucky levels of uncertainty that all of us find ourselves in. And joining us today to discuss this article is the first author of the article, Dr. James Flory, who is an associate professor in the Weill Cornell Medical College and an endocrinologist and associate attending at the Memorial Sloan Kettering Cancer Center. James, welcome to our podcast.
Well, thank you very much for having me, Neil. Yeah, to jump in, the overall purpose of this research was to start to understand how modern artificial intelligence programs like ChatGPT behave when you try to get them to answer clinical questions where there's real uncertainty as to what the right answer actually is. And as you articulated better than I will, that's a very common situation in clinical practice. Why do we focus on uncertainty in particular? So it's already pretty clear, as you implied, that for clinical questions where the right answer is known, AIs can do really well. So for a patient that presents with polyuria, polydipsia, and blurry vision, it should know that you need to test for diabetes next. And if it doesn't, there's a problem with the AI because it's not hitting an objective, correct answer kind of benchmark. If you ask it what the best first-line anti-diabetic drug is for the patient, that's a murkier question where different expert clinicians might give you different answers. As you said, this level of uncertainty is very common in healthcare. It's what clinical trialists and bioethicists call clinical equipoise, like profound clinical uncertainty, a lack of consensus. So what will an AI do, and how do you assess its quality as a tool for clinical decision support under these circumstances of clinical equipoise?
Yeah, and what fascinated me here is how you decided to go about this, because when there's not a clear right answer, there's not a clear right answer. And we'll come to discuss that, I'm sure, later. But what was the methodology? How did you approach this question?
So to study this, we took a library we had of 40 vignettes that were describing hypothetical patients with type 2 diabetes who needed a first-line drug. For each of these patients, we gave a paragraph or two of description with vitals, lab values, including eGFR, and a little bit of made-up medical and social history. We surveyed endocrinologists to see what they would do in these hypothetical situations. We gave them a multiple choice option from about 8 different drug classes. And then we also ran these questions through the AI GPT-4 program a bunch of times. And this was a fun paper because it's one of these papers where really we were fundamentally in a descriptive mode. We wanted to just say, how do the AI responses look compared to the human responses? We did have a more defined technical question where we looked at whether the AI gave consistent answers when you asked it the same question over and over again. But that's pretty abstract. I think it has more methodological than clinical implications, so I may gloss over that a little bit unless you prompt me back into it.
No, that sounds that I think we'll have enough to talk about. What were the results? How did AI do compared to the experts?
Things we learned. First, overall, the AI gave reasonable answers. Where models programs for even a few months before we did the study really couldn't handle these questions, wouldn't give you coherent answers, the GPT-4 program could. And there were some objective signs of high quality. For example, the AI virtually never chose metformin as an option for patients with eGFR less than 45, which meant it was following the letter of the FDA label very precisely. And that's without any specific prompting or fine tuning for this particular healthcare question. So that was impressive. The second thing, though, was that in spite of those signs of quality, if you looked at the overall pattern of GPT-4 responses, they were what I would call a little weird, to use technical language. Our endocrinologists that we surveyed, they chose metformin out of 8 options. They chose metformin for 31% of patients. And for the patients, for these hypothetical patients, when they didn't have significant CKD, that was more like 50%. Whereas GPT-4 chose metformin in only 12% of patients overall. And as you might guess, in lieu of metformin, it used newer, costlier drug classes quite a lot more. We just don't have the information to completely explain that discrepancy. We don't have enough insight into how these AIs work. They tend to be black boxes. But part of the reason is a third observation I'll note, which was that for some of these patients, we included a history of functional GI problems, just a sentence we dropped in there. And the AI would almost never give metformin to those patients. Like 2% of them, they would give metformin to. And it would describe its reasoning, and it generally cited concern over GI side effects as the reason. Endocrinologists didn't really seem to modify their decisions much based on that concern.
That's particularly fascinating because it seems like the other thing that's going on is GPT. This is a one-time event. To see the patient pick the medicine that would be the most likely to work, whereas I think those of us in clinical practice see our care of patients over time in continuity, and will often say, let's try this medicine because we think it's a good medicine, but if you get these side effects, call me or I'll see you back in a month and we'll figure it out from there. Does that seem correct as I'm listening? Is that at all also entering into what's going on?
I think that's a great observation. I think that's totally right. It reflects a limitation of this study a bit. You could argue we're not being completely fair to GPT-4 because we boxed it into this pretty narrow question and gave it only one time point to make a decision at. And actually, if you can formally try this exercise again on much newer models, they talk about options for counseling and recursively changing treatment over time. I think you're just absolutely right about that difference.
It's interesting. Loved the phrase that you used in the beginning of the discussion of the article, and I'm going to quote it here. You said, GPT-4 responses to hypothetical clinical scenarios were superficially reasonable and personalized to align with clinical guidelines. That superficially reasonable resonated as not a bad place to end up. I was very impressed with GPT, even though it didn't align perfectly with the endocrinologist. What were your thoughts?
Yeah, I was impressed with it too. I think it put me in a little bit of a trust but verify mentality with this thing. I think it has so much potential, but there are a few things that I think this paper and others highlight that we need to watch out for. Undeniably impressive. Really neat, for example, to see how precisely it could implement the FDA recommendations. You can see why these things do so well, a standardized test. But I wouldn't say that we want the model making decisions yet, and that may be very distant if that ever happens. I also think we want to be careful about how much it influences decisions, which it very likely is doing. I imagine patients sometimes ask it these questions before and after doctor's visits. Certainly for things outside of my comfort zone, I consult AIs offline, and what they think about things trickles into my clinical decisions, I'm sure. That means it's really important to think about why the model responses were so different from the expert responses. So if you handed over prescribing decisions to this particular program, you would get, as you said, superficially reasonable decisions, but they would add up to way less use of metformin and a lot more use of more expensive alternative drugs. Maybe that wouldn't be worse. It would definitely be more expensive, perhaps it'd be better for patients. It's hard to say, but it means there's a real potential impact for a change away from experts, and we need to understand what that means. And one thing, if you want to take a more suspicious posture here, one thing to think about is these models are trained on the entire internet, which almost certainly contained a lot of advertising content, a lot of pharmaceutical advertising content. And this is just wild speculation, but that could be one of the factors that sort of move the needle of these programs toward the newer drugs.
That part is pretty scary. I had never thought about that and how that advertising can influence the output. Although it seems to me that your point that we wouldn't want it making decisions is a critically important one. But what do you feel about its place in decision support? So you asked endocrinologists who are all expert in diabetes, but when it comes to particularly type 2 diabetes, 90% or so of the people taken care of are taken care of by non-experts, primary care docs who are doing their best to keep up with guidelines. Do you think the level of sophistication at this point, the answers that it provided, were such that it would be reasonable to be incorporating this as decision support for people who are non-experts?
I honestly think that's a great question. I've never been put on the spotting quite this way before. I like it. It's a great question. I think the answer is actually no. I think it's great that we all have access to it. I think, especially for a non-expert, the ability to spitball with one of these AIs can be very helpful. It's actually what I took your question to imply, though, is we might be putting it in the EHR, making it a window you can quickly get to, and labeling it decision support. I wouldn't want it to have that kind of authority for regular providers. Clearly, it would do a few things right here. It would prevent some people from giving metformin at dangerously low GFRs, which that is definitely something non-experts do more often than you would think. But the ways in which it might tip the scales in other directions worry me. This potential bias toward newer medications is one issue. And with this generation of the AI, the thing with GI side effects could have been a problem too. It seems to be exquisitely, unbelievably sensitive to that concern.
Yeah.
I think maybe the reason is that whole internet training also included a lot of message boards and social media, where if you've ever gone and looked for this, metformin does not generally come up as a drug somebody liked in that setting. The social media tend to be full of people complaining bitterly about the side effects. And so without anybody having ill intent, I think these models may have incorporated that voice to what I think is an excessive degree and might shove providers away from metformin to an excessive degree.
That's fascinating and so important for us to be aware of. Now, the last question I'm going to ask you to address, because we could probably talk for an hour, you and I, about this, is you talked about the potential for tuning the model if you were to use it. And can you explain that? How one might do that as an individual and as a system if you were using it?
Yeah, so I always get anxious about these questions because a true AI expert will rip apart anything I have to say, but I'll give you my layman's understanding of what you can do here. Building these models from jump, unbelievably expensive. Nobody can just do that. But what's interesting is you can do a lot to modify their behavior. One technique is called prompt engineering, and it's this idea that just how you ask it a question will influence the answer it gives you. So we tried this in the paper. We said things like, please default to metformin if it's a reasonable option. And that, from a certain point of view, fixed it. It made it fixed in quotes because we don't know really what the right thing to do is. But that aligned its answers much more closely with providers. And especially if you were releasing this model for use by a bunch of clinicians, you could build it so if somebody asks it diabetes questions, that instruction to default to metformin is embedded in a layer between you and the device and the model. That's a very cheap way of adjusting what these things do. There are a lot of other techniques the specialists know about for fine tuning, but that's the simplest one.
No, but it's really interesting, James. I'm listening to this from the perspective of someone who uses ChatGPT sometimes to find information, and it makes me think, and let me know if I understand this correctly, that if I had a patient and I was looking up the answer to a question where there could be more than one answer, I might say for one patient, please give me an answer that is very attentive to cost effectiveness because this person does not have good insurance, does not have insurance at all, and does not have very much money to spend on medicine. Or on another prompt, I might say, this individual in front of me is very worried about progression of their kidney disease, has excellent insurance that pays well for whatever medicine choice the literature says is best. Would that be a way to optimize if we were to choose, which I know you're not recommending, but people are doing it, if we were to choose to use ChatGPT or whatever open evidence or some other model as a source of helping us find information and make decisions, would that be one of the ways that we could get better answers?
Yeah, I think that's beautifully put. And you could apply that strategy and you could apply it iteratively when it gives you an answer for a patient. If you feel like it maybe didn't take into account cost issues, you could prompt it to do. But the the thing I really like about the example that you gave though is that was a dialogue with the AI where you really put yourself on an equal footing with it and were really dynamic in how you consulted it. Because I think these things are extremely smart. I often think they're smarter than me, which means one day they might be smarter than some of my colleagues, but they don't always share our values. And that's why I think
Mm.
it's important to engage with them dynamically in the way you talked about just now.
Fantastically interesting discussion. Fantastic article. Dr. James Fleury, thank you so much for joining us.
Thank you very much for having me.
Our next article is from The Lancet. It looked at long-term health outcomes in patients with diabetes 12 months after hospitalization with COVID-19 in the United Kingdom, a prospective cohort study. So this FOSP-PHOSP COVID study is a multi-center long-term follow-up study of adult discharge from hospitals between February 2020 and the 31st of March 2021 in the United Kingdom following COVID-19, and it involved a detailed assessment at 5 and 12 months after discharge. The association between diabetes status and outcomes were explored using multi-linear and logistic regressions. The researchers found that people with diabetes who survived hospitalization with COVID-19 displayed worse physical outcomes compared to those with diabetes at both the 5 and 12-month period. The patients with diabetes displayed higher fatigue, really only at 5 months, frailty, lower physical performance and health-related quality of life, poor cognitive function. The differences in outcomes between diabetes status groups were largely consistent in both the 5 and 12-month period. In regression models, the differences in 5 and 12 months were attenuated after the researchers adjusted for BMI and presence of other long-term conditions. Neil?
John, it's really something to think that next month will be 5 years since the World Health Organization declared COVID a pandemic. Thank God the world is very different now than it was 5 years ago. You and I remember that time very well. Over that period of time, our knowledge of COVID has, of course, increased enormously. The danger of COVID has decreased just as much. We're not as worried now about people being hospitalized, and the incidence of long COVID has decreased. Remember, this study is data from that first year of COVID, so the data might be different now. The study ended in March of 21. It's pretty clear from more recent studies that long COVID is less common now than it used to be, but it is still important. When I think about long COVID, there are two large areas. One are the physical manifestations that are easily measurable, the increase in venous thromboembolic disease that occurs after COVID for 6 to 12 months, the increases in stroke, in MI, in pulmonary embolism, changes in lung function that are measurable in some people and quite severe in some people post-COVID. The other is a set of symptoms that impairs life enormously. And this was here where the study focused on teasing out what are the effects in people with diabetes versus those who did not have diabetes. It was also interesting because they were able to tease out using regression analysis, is this effect primarily driven by diabetes or very possibly by obesity, which is related to diabetes, and often many people with diabetes have obesity as well. And is that the driver of this effect? Regardless of the driver, it appears that people with diabetes have a higher rate of things like fatigue, things like frailty. They have lower physical performance scores, lower quality of life, and even COVID even has an effect on cognitive function. All of this lasting for anywhere from 5 to 12 months or longer after COVID. And there isn't great treatment for long COVID. So what do we do about this information? The first thing, and probably the most important thing, is to recognize the benefit of vaccination. There was a wonderful review article in Lancet a few months ago, and in it they discussed that individuals who have 3 vaccinations for COVID have about a 2/3 lower risk of developing long COVID after they have a COVID infection. So vaccination is critically important. Staying up with COVID vaccination, critically important for people with diabetes. Then, the effect of antivirals. Here the data is more mixed. It might be helpful to decrease the risk of long COVID in individuals who are at high risk. And then, of course, masking in high risk situations. So we have a lot still to learn about long COVID. I'll refer people to that review article for some discussions about an approach to helping people with long COVID. It remains a vexing problem and remains an issue that we have a lot more to learn about. Our next article is from Diabetes Care, titled Risk of Nephrolithiasis Associated with SGLT2 Inhibitors versus DPP4 Inhibitors Among Patients with Type 2 Diabetes, a Target Trial Emulation Study. The authors looked to compare the risk of nephrolithiasis among type 2 diabetes patients who initiated SGLT2 inhibitors versus DPP4 inhibitors. And they wanted to look at this in people who had never produced stones before and those who had produced stones before. To do this, they used a 2010 to 2021 Korea National Health Insurance Service database to compare initiators of the 2 medicines. The primary outcome was incident nephrolithiasis, and they used osteoarthritis as a negative control outcome. They looked at over 17,000 propensity-matched pairs of SGLT2 and DPP4 inhibitors pooled from stone never and stone ever formers. Over a mean of 654 days, the risk of nephrolithiasis was lower in individuals who were placed on SGLT2s, and that had a hazard ratio of 0.54, so about 50% lower. Among never formers, those who had not had stones before, the hazard ratio was 0.43. Among ever formers, those who had stones before, the hazard ratio was 0.64, and there was no relationship found for osteoarthritis encounters. John?
So, Neil, an interesting study, and just want to do a little kind of background on it. So, when we think about renal calculi, kidney stones, 1 in 10 Americans will have one in their lifetime, more common in men than women. Of the stones that we're going to see in the general population, 80% of them will be calcium oxalate, 10% will be uric acid, and then the rest will be a variety of things. So when you look, do patients with diabetes have an increased rate of kidney stones? Well, in some of the nurses' health studies, some of the health prevention longitudinal long studies, some different answers, but roughly about a 30% higher rate of kidney stones in patients with diabetes versus age-matched controls. Are the stones different? Well, instead of that 80-20, it probably, or 80-10, you're probably getting in that 70-20. So a higher rate of uric acid stones in a patient who has diabetes versus a patient who doesn't. So that's kind of our kind of landscape we're based on. Medications that can lead to kidney stone formation, things like topiramate that someone might use, loop diuretics might cause renal calculi, It's not completely clear are any of the diabetes medicines contributors, although in some studies you will see sulfonylureas kind of labeled on a table as a potential contributor without a whole lot of data connected with it. So we're kind of faced with a patient who has diabetes, who has an increased rate of kidney stones. So what should we do? Well, you know, when you and I are in medical education, I love kind of BOGOs, buy one get one free. So if you can ever have a patient who has diabetes, and you need to add something in, an SGLT2, if it's going to decrease that rate by about 40-50%, as we saw in the study, great. I don't think it's going to be the primary approach to this. And if you really look at kidney stone prevention and recommendations from the National Kidney Foundation, really we want people to be more hydrated. So drinking enough liquid, certainly all the young people are carrying these huge gallons of liquid with them at all time. Great. So being well hydrated. Calcium supplementation. Actually, taking calcium supplementation, that's not necessarily what's causing that, or calcium, unless someone's taking a huge amount. People don't have to eat a low calcium diet. The oxalate, that you might see in certain vegetables and sweet potatoes and things along those lines, if people are going to consume these foods, if they consume them with the calcium that should be in their diet, the calcium and oxalate will bind up in the gut and not have to kind of play themselves out in our kidneys. So that might be something kind of diet wise. There is an increased rate in people who drink sodas, and the decrease in getting people off some of the sodas, especially the brown sodas, wasn't super duper high. The really highest amount was really seen in people who were given citrate as a supplementation, potassium citrate, people who were hydrated more, people who moved to a low salt diet. So having a high salt diet can be a contributor. And then there are things like hydrochlorothiazide. There was a study last year that was kind of mixed, that really didn't show a whole lot of benefit from hydrochlorothiazide, but probably we need to be in the 50 milligram doses of hydrochlorothiazide really to make that difference in renal calculi, which then leads us to having higher incidence of hypokalemia, hyponatremia, hyperuricemia. Knowing what the stone is, I think, makes a difference if someone can get the stone, because certainly allopurinol for our patients who have urate stones makes a big difference. And I think that's an easy enough thing to add into someone's pharmacopoeia. But I think this study is great as a kind of an add-on, and it talks about the pleiotropic effects of SGLT2s, which we seem to talk about month over month in some different setting or another. This is yet one other one. But I probably wouldn't say, hey, you have kidney stones, let me put you on this. A little bit of that diuretic process that we might see for the SGLT2s might make a difference. This was reported out a couple of years ago at one of the American Urologic Association meetings, and they also had a paper at the same time that actually talked about some positive effects with decreasing kidney stones in our GLP-1s, which will increase the citric acid concentration in the kidneys. So I think some kind of interesting stuff, but certainly a common problem that we deal with our patients with diabetes. We just have a lot of answers that aren't pharmaceutical.
For our next article, we're going to discuss something we don't usually do, which is a discussion article that was published in JAMA Internal Medicine titled Early Screening for Latent Autoimmune Diabetes in Adults to Improve Care Beyond the Routine. I'm saying we don't usually cover articles like this because usually we do deep dives into research articles or guidelines. But I thought that this is such an important topic, LADA, that this article was so well done that I invited one of the authors, Bruno Alvarez Concito, to join us. Dr. Concito is an assistant professor of medicine and clerkship director of internal medicine at the Ochsner LSU Medical School. Bruno, thanks so much for joining us.
Absolutely, Neil. Thank you. Thank you for the invitation. Yeah, this paper, it appears in JAMA's Teachable Moment series, and it basically centers around a case that I think is gonna sound familiar to a lot of your listeners. And it's basically a patient that was initially basically seen whenever he was in his early 30s, whenever he presented to the emergency department with marked hyperglycemia and being obese, was diagnosed with type 2 diabetes at the time. But then over the years, he kept being uncontrolled while losing weight. And when I saw him close to 10 years later, his BMI had normalized, and yet his A1C remained at 13. And that kind of made us revisit the diagnosis of type 2 diabetes and think a little bit more broadly. We tested for LADA using basically anti-glutamic acid decarboxylase or anti-GAT65 antibodies that ended up coming positive, and C-peptide was tested to be low. We changed them to insulin, but as I'm sure your listeners will know, at that time, kind of the damage had already been done. He had developed nephropathy, and a lot of the macrovascular complications were already established, and he ended up having multiple amputations. So we really wanted to highlight this case because it's unfortunately pretty typical. Patients with LADA are initially misdiagnosed as type 2 diabetes pretty frequently, with some series publishing up to 40% of cases. So we thought that kind of bringing this to everyone's attention and kind of reviewing some of the more recent literature would be helpful.
And I really think it was, because I think this is one of those cases, and he presented with a BMI over 40, where most of us would do what was done here, which is we wouldn't have thought much about it other than to start treatment for type 2 diabetes. And clearly, we need to start thinking more about it. When we think about autoimmune diabetes, so most autoimmune diabetes is typical type 1 diabetes, but then we also have LADA. Can you give us a sense, how common is LADA? Should we really be thinking of it in adults?
Yeah, depending on the series that you look at, anywhere between 2 and 12% of adult onset diabetes is going to end up turning out to be LADA. And I think we used to, at least whenever I was in medical school, autoimmune diabetes pretty much equated type 1 diabetes. And I basically thought about it as, sure, it happens in children, mostly with family history. But now we know that more than 50% of cases with autoimmune diabetes present in people that are over 20, and up to 90% of cases do not have family history.
Isn't that something? So, really important for us to understand, which then begs the question, when should we be thinking about it?
Yeah, so there was a great paper by Bussetti and all in Diabetes in 2020 that we referenced, and it's a great read for anyone interested in this topic. And I think they were arguing that we should probably be testing a lot more broadly, especially if there's high risk features like being younger with an age less than 50, personal family history of autoimmune, having a BMI that's normal, less than 25, or if you're having an inadequate response to your typical oral glucose lowering therapies.
Fantastic. And then when we think that we need to now test for LADA, what labs do we order?
Yeah, so I think again, when I was first starting to do this, I think I know most of us were taught first do the C-peptide because it's a little bit cheaper, and then if that's abnormal, then you go and do the autoantibodies. But I think two things have happened. I think the price of the autoantibodies has decreased, especially outside of the U.S. But I think also we've come to understand that it's better to test first for autoimmunity, and then once you know if the patient has an autoimmune background to their diabetes, then you can test for basically the pancreatic cell function with C-peptide, and then target your therapy based on C-peptide levels.
That is so helpful. And I'm not going to go over now how to approach therapy. You go over it nicely in your paper. I know they do in the paper that you referenced, with what level of C-peptide would lead to what treatment. I don't think we'll remember those details the next time we see the patient, but we now know to think about LADA. We know what to order in order to make the diagnosis, and we know that we can go to your paper to find out the details of how to approach treatment. Thank you so much for joining us.
Absolutely, Neil. Thank you.
Our final article for this month's podcast was published in Diabetes Care and is titled Project Echo Diabetes Trial Improves Outcomes for Medically Underserved People. We'll hear more about what Project Echo is in a moment, but let me just say I think this is so exciting because it's an educational project. It's what we all care about, is educating each other. That's what this podcast is about, and what we always hope is that it'll affect patient care. And joining us today is the first author of this article, Dr. Ashby Walker, who is Director for Health Equity Initiatives at the University of Florida Diabetes Institute. Ashby, welcome back to our podcast.
Thank you so much for having me and for representing our whole group on this podcast today.
Ashby, there's no doubt, and we've talked before, you do some amazing work in the area of health equity, really important work. Can you tell us for this article, one, explain what Project Echo is, and then the background of why you all undertook this particular project?
The Project Echo model was founded at the University of New Mexico in the early 2000s as a way of trying to reach medically underserved communities that may not come to see a subspecialist for care. So Dr. Aurora started this model. Really, the work focused on hepatitis C initially, and the heart and soul of a Project Echo program. Echo stands for Extension for Community Healthcare Outcomes. It's a provider-to-provider empowerment model where you have a team of subspecialists that train primary care providers in how to be better empowered to do subspecialty care in the family practice setting. So this model has been used all over the United States and the world to try to better reach communities who may not see subspecialists, who instead rely on a primary care provider or a family practitioner in a community setting for their comprehensive medical care. So that model has been used in lots of different disease models, both chronic and infectious. What we wanted to do with our Project Echo program, while there is so much research on the Project Echo model in terms of its power and its ability to improve provider level knowledge and confidence, there is less research on whether or not this model can actually improve patient level outcomes, and especially studies that were designed with randomization and rigor so that we could apply the same standards of randomization that we would in any clinical trial to understanding this intervention in terms of its power to reach people.
And that really is the holy grail of education, is in order to change clinician behavior, not just have knowledge acquisition. How did you look at this? What was the methodology that was used?
So for this particular project, we had a grant from the Helmsley Charitable Trust, and this was a large collaboration between Stanford University in California and the University of Florida. And we recruited federally qualified health centers to be what are called our spokes in this program. So in a Project Echo model, you have your hub team. So in diabetes, that is a team of multidisciplinary specialists like adult endocrinologists, pediatric endocrinologists, behavioral health specialists, pharmacy specialists, and we provide the training to the spokes. The spokes are the primary care provider. If you're trying to improve health outcomes for underserved communities, we strategically targeted federally qualified health centers because FQHCs in the United States provide care to over 30 million medically underserved people. They're located in medically underserved areas, and we know that they're a really good strategic partner for provider empowerment. We used what's called a stepped wedge design, which involves randomization of the FQHCs that we recruited into the program. There were 20 total, and they had a randomized start date, and we had a control period and then implementation of a 6-month intensive education program for the FQHCs through teleeducation with our hub team. We assessed baseline, provider level, patient level, and health center level data. This was a massive data collection effort. then post-intervention, to really see if the Project Echo teleeducation could not just improve provider confidence, but could it reduce health disparities for underserved communities in the FQHC?
So that is a very ambitious goal. What were the results?
It took, I want to just say, so many dedicated multidisciplinary people working together to make this happen. It also took a large amount of funding. And the results we saw were really amazing. We saw from baseline to post-intervention a statistically significant reduction in the proportion of people that were greater than 9% HbA1c within the FQHC setting. We saw a statistically significant increase in the use of continuous glucose monitors and insulin pumps. We definitely saw the same types of outcomes that are typical in a lot of Project Echo evaluations, meaning that the providers had more knowledge and confidence. But importantly for this, we show that with a large randomized project across 2 states, this model has the potential to reduce health disparities in underserved communities living with diabetes that were highly diverse.
That is fantastic and such important results because what we all want to do is improve patient care and decrease health disparities. What do you see as the clinical implications of these of the study that you did?
I want to say I think that the power of this model lies actually with the provider that's in the FQHC setting because she has the trust of her community. So when you're looking at FQHC providers are some of the most diverse providers in the United States. And in order for this to work, you had to already have an established relationship between a patient and a provider. So the FQHC, PCP, and the people working in the FQHC setting already have the trust of the medically underserved community. I think oftentimes in trials, we are trying to do an intervention, especially when we're working with historically underrepresented communities, and we don't have that trust. And that is really hard to build in a quick manner. But this model leverages what is already there, an established provider relationship and someone who is then able to take knowledge and disseminate it when they already have somebody that really does trust them for their care. So I think it takes the brilliance and the knowledge of the multidisciplinary diabetes care team and it brings it into a setting where it is able to be disseminated in the best way possible to people.
It's interesting as you say that, I'm reminded there are so many pieces, so many nodes that go into the point where patients see improvement. First has to be teaching, then there's knowledge acquisition by the clinician. The clinician has to then use the knowledge, but the patient, as you're saying, if there's not trust there, then the whole process ends where there is a lack of trust. The patient has to do what is recommended. And what is beautiful about the process that you just went over is that all those pieces are in place, particularly the last part of that funnel, patients being able to do based on trust what has been recommended. Can I ask you a question, which is, I've been involved in Project Echo, and one of the things that I've always thought was particularly exciting about it was the opportunity for bi-directional interaction, that the clinicians who are learning here in the spokes are able to ask the experts questions. Is that something that, as an educational expert, you feel is important as a part of the learning process?
Absolutely. And this, we give credit to UNM's model because the heart and soul of the Project Echo model, which supersedes our research program, it is really using what we call all teach, all learn. So everyone in the learning community has something valuable to offer. And in the setting where we had endocrinologists that are global experts in diabetes with primary care providers that came onto the calls, they could ask questions, but importantly, you build and cultivate a culture where there is no wrong question. Nobody is seen as a bigger expert in the room. Everyone brings something valuable. And I think that in those types of learning environments, you maximize the potential of this type of intervention because then You're not operating under someone being afraid to ask a question or to be transparent. It really becomes such a community of learners together.
All teach, all learn in a community of learners. I'm leaving this discussion inspired. Dr. Ashby Walker, thank you so much for joining us.
Neil, thank you so much for having us today.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.